More than 90,000 cases in a single day, a 56% increase in COVID cases in India in 24 hours. The third wave is here, triggered by Omicron, but do we need a brand new protocol? I'm Barkha Dutt and you're watching the Mojo Story. Let's take a look at these fast-moving developments when it comes to India's battle against COVID-19. A single day spike of 90,000 cases has now been recorded, but there is a silver lining in these dark clouds. Hospitalization rates, ICU rates, and the need for oxygenated bed continues to be low, even as Omicron drives the COVID third wave surge. The medical community is divided on whether India needs a new set of protocols. We even have some epidemiologists suggesting that asymptomatic patients should not get tested at all. The government seems to be agreeing only so far as asymptomatic contacts are concerned, saying you don't have to get tested. How can we reimagine COVID rules for an Omicron age? Hasn't it become necessary to not use the instruments of 2020 and 2021 in 2022? Should one of the changes be to stop testing randomly, especially for those who may be feeling mild symptoms or no symptoms at all? That is our question on the program today. Our panel of experts is here. We're joined by Professor Bhramar Mukherjee. She is with the University of Michigan and has done some of the most important modeling work in the last 2 years of the COVID pandemic. So it's great to have her back on the program. Dr. Harsh Mahajan of Mahajan Imaging, who has been at the front line of the COVID battle, especially when it comes to testing and vaccination, and the use of AI, artificial intelligence, is also here with us. Welcome to the program, Harsh. Dr. Lancelot Pinto is with us. Lancelot was among the first to sound a warning against the indiscriminate use of steroids in wave 2, and in wave 3 he has some prescriptive warnings as well against indiscriminate medication. We could be in the danger of doing that all over again, so we'll be asking him about that. And Dr. Chandrakant is with us. Chandrakant has quoted controversy online by being among those suggesting that we need to abandon random testing for the asymptomatic and focus now on hospitalization, mortalities, and the vulnerable, because the numbers triggered by Omicron are going to be just too big. Now, I want to start with you, Bhramar. I will play an excerpt from an interview I did with Dr. J.P. Mulyal in just a moment. But I saw that you said online very vociferously that you believe that testing must continue as aggressively. Let me ask you, what is the point? Omicron is clearly in community transmission, widely. It's galloping through India as it has galloped through the United States of America. What will testing, in fact, tell us? Do the old rules of test, trace, isolate even make sense anymore?
Thanks, Barkha. So I have been following a protocol since, I have been traveling a lot. Right now, I'm in India. I have been following a protocol with rapid antigen tests at home. And that's because I have been traveling, I have been exposed, and my parents are here at home. So I want to diagnose myself as soon as I catch the infection. So this is to protect myself as well as to protect my parents. I have limited time with my parents, and if I am actually detected early, I can isolate. So that's one of the reasons that my individual behavior may change if I actually have a test result. And then I can protect my family. That's a cluster level protection. And then finally, as a modeler, I really worry if we are not testing, then how are we going to have the data at a national level? We do not have a hospitalization dashboard. We do not have a hospital ICU capacity dashboard nationally available. If we had all of those clinical data available, I would feel more comfortable with reducing tests, but we don't. And so without that, as a modeler, we don't have any track on the pandemic. What are the hotspots? How is this moving across geography? So I think at a personal level, at a family level, and at a population level, I see a lot of value in testing.
Okay, that's an important point that we are missing a national hospitalization dashboard. But as we see these figures on our screen, in fact, there are cities like Mumbai that do have such a dashboard. And the Mumbai Civic Commissioner was telling me earlier that he now believes that any decision on restrictions, of any kind should be done by hospitalization numbers and not by caseload numbers. And to me, at least, that makes complete sense. Now, I want to play out before I come to my other experts. JP Mulyal is a member of the government advisory body on COVID. He often says things that others do not agree with. People have pointed out that he didn't think the second wave would be as bad as it turned out to be. So his appraisal at that time, yes, was wrong. But this is what he has to say about asymptomatic people being subjected to tests.
There is a disease called COVID-related pneumonia to be managed in a good center with all the facilities. Those physicians would like to know if it's corona or not. We don't need to know every cold, every sneeze, is it due to corona? There's no point knowing. Okay, it's there all over the place. So be comfortable about that and say, don't test unnecessarily. Let doctors, when they need to look after patient in a hospital situation, let them test. Okay. Now, luckily, the whole world is involved in it. So even the testing in the aeroplane, all those things are just an exercise in futility. So where we go to it, that understand the virus. It is harmless as of now. Not for everybody, I agree. And those people have to take special precaution for themselves. That's the way to go.
Okay, so very clear statement there. Don't test unnecessarily. Testing plane loads coming back is futile. He also went on to say in that interview that he believed that isolation doesn't work, that those who have mild symptoms don't bother. That actually every sneeze, as he said, doesn't have to be analyzed for Omicron. Dr. Pinto, is there any merit in what Dr. Mulyal is arguing, given the pace at which Omicron is already present, and given that thus far most patients, 90%, I would say, are asymptomatic?
Hi, Barkha. Thanks for inviting me to the show. I definitely think some of what he says makes sense. For example, if you have an index case at home who is positive, you can just assume that you will be positive in all probability, given the velocity with which this is spreading. So whether asymptomatic contacts in that household would add any value by testing, I'm not totally convinced. I think one of the biggest problems also which we need to anticipate is that testing labs and our testing infrastructure is going to get completely overwhelmed. Already in Mumbai, I know of my patients who are telling me that it's sometimes taking them 24 hours or 36 hours or close to 1.5 days to get the test done, to get RT-PCRs done. So I think it's fair to lessen the burden on at least RT-PCR. So maybe you want to do home antigen testing. Maybe if there is no shortage of kits, that's something that we can look at. But I think the burden on RT-PCR testing needs to be lowered down before we reach a situation where people who really need that test for clinical decisions. So if someone's elderly, if someone has risk factors, whatever antivirals we may or may not have need to be given within a time frame. So delaying diagnosis in those high risk individuals is very risky. So I think there should be some sort of a triage, and the triage is, I think it's fair. If you don't have symptoms, you're in contact with somebody, assume you are positive, isolate. While as if someone is high risk and has symptoms, or if someone is a high risk contact, maybe reserve the RT-PCRs for them where it actually converts into a clinical decision.
Yeah, and I would agree with that. That you cannot have your testing infrastructure under crazy pressure, and if the cases are going to show the kind of exponential percentage increase that is happening right now, 56% in a single day, then we could be looking at several lakh cases a day very, very, very soon. I would say even maybe by next week. Dr. Mahajan, some of us have come to your laboratories for RT-PCR testing and so on. Are you seeing a spike in testing, and do you see there's any merit in being more selective on who we do at least RT-PCR tests on?
Good evening, Barkha, and thank you for having me here. I'm in the company of stalwarts, but after having spoken to epidemiologists as well as infectious disease specialists, and seeing the surge that is there. We all know there's a huge surge. The numbers bear that out, and I'm sure there are many that are not being diagnosed. The Our systems are much more active on testing, especially RT-PCR, than they were even a week ago. Also, what we are finding is that in our own social system, we are finding more and more people who are positive. So, in this situation, I think it is a must, because remember that especially RT-PCR tests are going to be finite in number. We did achieve a very large increase in capacity during the second wave, and that capacity within the country stays intact. I think if push comes to shove, we would be able to do at least 1.5 million or 2 million RT-PCR tests a day in this country. And so, till such time that that system doesn't start getting overwhelmed, we should do testing. And home testing is also important and forms a part of the entire chain of testing. But what we need to do right now is actually prioritize those with symptoms. I think whether it's a sneeze or a sniffle or a little pain in the throat, they should be tested, because right now it's the winter season, especially in North India. It's also a mostly polluted atmosphere that we have. So there is a mix. And between this mix, it is important, especially the symptomatic ones, to differentiate those who have COVID from those who do not. And the only way is to test. You may test at home, and if it comes negative, you may still be positive, because the rapid antigen test is not so accurate. So the RT-PCR still remains the gold standard. But as regards, random testing in the asymptomatic, I think time has come to stop that. Of course, contacts of those who've tested positive, it'll again, if they are willing to, quarantine themselves in their
Yeah.
homes for those 5 to 7 days that is necessary, then there is no need to test. And as Dr. Pinto said, in a family, if someone is positive, then you can, with this Omicron especially, you can presume that the others will be positive, but they should actually quarantine and not be going around saying, I didn't test, so I'm fine. Then there is also this second group of people, like healthcare workers. You don't want to go to a hospital or come to a lab or a diagnostic center and not know that, whether those people are positive or not, because the asymptomatic can also spread the disease. Of course, masking here is very important on both sides. But even then, we, at least in our centers, we have about 800 personnel. Every third day, we are testing everyone with RT-PCR. And lo
And
and behold, we are picking up asymptomatic, and they are being, sent home for 5 days. And then, as the norms evolve, that is what
yeah.
we are following. So there will be, especially airline pilots, the air hostesses, restaurants, So, but I would agree with Dr. Lahariya that random testing, going to a metro station and doing testing, I think that should be stopped, because the system is finite.
Okay. I would still sort of be somewhat cynical here and ask Dr. Lahariya, what is the point? Because if we are going to keep testing those, let's say, who are asymptomatic but have come into contact with someone who's positive, I fear that the volume that we are confronted with soon is going to be so large that it's actually going to be, as Dr. Mulyan said, an exercise in futility. Chandrakant, when you argued this, you got a really violent backlash. People suggested you were being cavalier with COVID, you were being dismissive. How do you justify, in a way, your argument that a completely new protocol is needed?
So thank you. So everyone has spoken more or less similar line, but let me put in a different perspective. So testing in COVID-19 or any disease is done with a particular purpose, individual benefit and public health benefit. We test people if there is an individual benefit of doing something. For example, if somebody has typhoid, we want to get person tested for typhoid, and if the person is found typhoid positive, then you start treatment for typhoid. But in COVID-19, asymptomatic or mild symptomatic, even if they found out that they are COVID-19 positive, there is the case management is not going to change. So there is no individual benefit of asymptomatic or mild symptomatic being tested. That's one part. And then second point, reason for testing is public health benefit. In the beginning of pandemic and even till recently, the idea was that if we identify a person who is COVID-19 positive, then we can control the rest movement of that person through the isolation or quarantine, isolation in this case. So it will have public health benefit. But with the current rate of transmission, especially with Omicron, which spreads so fast in 2 to 3 or 4 weeks, then there is no benefit of uh, identifying asymptomatic person, because if you identify 5 asymptomatic, there would be 200 asymptomatic who have not been detected. So there is neither individual benefit nor public health benefit of testing people who are asymptomatic or mild symptomatic.
So according to you, who should be tested?
So, okay, so now this is a general rule. That does not mean that nobody should be no one asymptomatic should be tested. That means, of course, healthcare worker, anyone who can pose risk to others, who are involved in public service. So, healthcare worker should, even if they are asymptomatic, exposed, they should be tested. Or any frontline worker, healthcare, and the people in the airline industry. So, there should be some people who should be tested. Then individual can make a choice that, okay, I'm asymptomatic, I want to be tested. So as a government policy, this should not be that everyone should come forward and get tested. But if an individual want to get himself or herself get tested, I think that's the right choice they are making. But it should not be a policy. So what we need to remember, that the way governments were saying that test a few months ago, that policy dropped. Now I want to come to the final point, that we are talking about the rapid antigen test, or people can do tests at home. So we have a data, but we need to remember that even that is not helpful. If somebody is COVID-19 tested positive on rapid antigen test, but there is no system in India to record that home testing in the public system. So we would really never know what that person is going to do after that. It might be benefit for
Well,
that.
there are technological apps now available to link that self-test to the database, but the accuracy, as Harsh just pointed out, is not cent%. So we've had many cases where people have tested negative on the antigen and then positive on the RT-PCR. This has happened with so many people I know. But I think the important point you raised, which I want to take to Professor Bhramar, Mukherjee, and then to the others, is what is the purpose of testing? It is individual and family protection, and then there is public, there's a public health issue. At this point, what is worrying the whole world is that if a sizable number of your healthcare workers are sent into isolation, then your healthcare system might collapse anyway, and not collapse vis-a-vis COVID. It is going to collapse vis-a-vis so many other diseases that also need urgent intervention, because you're just not going to have enough doctors around. So even perfectly asymptomatic healthcare workers could be pushed into prolonged isolation that Dr. Mulyal is arguing is no longer necessary. Now, I know that it provokes a lot of people to suggest that Omicron is mild, and the WHO is disagreeing with that, but that is how, at least pathologically, it has played out for the bulk of patients thus far. Bhramar, go ahead.
Yeah, so a couple of things. So I think that you're absolutely right that one is for surveillance and one is for diagnostic testing. So I think that the US government is being criticized, and rightfully so, for not flooding and sending free at-home tests to citizens so that they can take their own personal precaution and really keep getting tested. The situation that I mentioned, that it may be mild for me, but it may not be mild for my parents. So you are in a situation like that. If you have at-home testing capacity to detect, and you are getting going around and you are exposed. So I think this is the responsible thing to do. But there is an access question for self-tests. In England, people can get 7 free tests every day, mailed by the government, by National Health Services. So we are not at that point. Even in US, we are not at that point. But I can tell you that this really helps to keep systems open. Right. So if you want to keep schools open, if you want to really protect the
But
vulnerable.
look what's happened, right? What's happened is that schools have been closed again. And when you look at this volume of caseload, it creates so much panic that the first thing that gets hit are schools. And that is why I am arguing that the dashboard must be for hospitalization instead of cases. Why, if you had such a dashboard, Professor Bhramar Mukherjee, would you then be more comfortable with the focus not being on testing?
Yes, so I think that we has seen a steep learning curve in terms of public health messaging. It has become as confusing as it gets, as you pointed out, that saying that Omicron is mild, but the sheer volume of it is really crumbling not just the healthcare system, but the workforce. In US, essential services are being disrupted. So I think that this is very important to point out that this is not the nature's vaccine, and overall getting Omicron and letting it rip through the population is a good strategy. So I completely agree that if we had national databases where we are tracking the hospital capacity dashboard, the relevant metrics in terms of hospital admissions. But I can tell you that if I ask anyone that what percentage of people got admitted to hospital in 2020, in 2021, what is the breakdown by age and sex, that metadata does not exist, even for a team like ours, which have been modeling the pandemic for 2 years. So how can we track the pandemic without any data?
Okay, I think that's a fair question. So let's play out a bit before I come to Dr. Pinto and Dr. Mahajan of what Mumbai's top commissioner had to say. He had actually a lot of data. And among the things that he shared was that recovery is mostly taking place, unlike in Delta, within 5 days. That is his feedback from all hospitals in Mumbai. 90% are asymptomatic. When the day I spoke to him, which was yesterday, he said that less than 5% was the hospitalization needed in the city, and no ICU bed had been taken up in Mumbai. Now, I've seen SOS and messages on Twitter which suggest somewhat different, but this is the official data from Mumbai. Let's listen to Iqbal Chahal on the trends emerging, at least from Mumbai.
For example, yesterday we got 8,049 cases, and out of this, 503 were hospitalized. 91% yesterday were asymptomatic, and out of symptomatic also, half of them went to the hospital. And only 56 patients were sent on oxygenated beds out of the 8,000. And that also, as a matter of abundant precaution, people with high comorbidities, asthma, lung problems, people in the age group of 80, 85, 90, such people were put on oxygenated beds. Not that they required it, but a matter of precaution. So, and plus, second thing is we just found is that the turnaround time is 3 to 5 days. A person tends to become negative in 4 days, maximum 5 days. And that is a great factor for us because it vacates the bed.
So those are important data points. Mumbai is also a highly vaccinated city. Dr. Pinto, it's your city. You're there. And I think Mr. Chahal made the point that the vaccination rates in the city are quite high, which could be holding people's defenses against hospitalization. You have a prescriptive column out in the Express with some do's and don'ts. Thankfully, we seem to have learned some lessons. For example, the Indian Council of Medical Research is advising against indiscriminate use of molnupiravir. So we are seeing some precautions against random drugging. Go ahead with what you'd say at this point, Dr. Pinto. Are you able to hear me?
Yeah, I think I lost you there, Barkha. But can you hear me? So with regards to molnupiravir, I think these red flags were already raised. If you see the FDA approval in the US, it already said that women need to be on contraception while they use it, and for I think 4 days after, men need to be on contraception for 3 months after the drug. There were some concerns related to carcinogenesis. The problem is that we tend to swing from one end to the other very often. So either it's indiscriminate use across the board, young individuals all over the city receiving it, or then there's this paranoia that this is a bad drug and should not be used at all. So I think the drug has some merits. It has shown some benefit in the clinical trial that is used, in which it was used. But of course, the clinical trial was conducted in unvaccinated individuals with risk factors. So this is one nuance that we need to remember while prescribing the drug. The second thing is, the concerns related to fetal abnormalities, the concerns related to carcinogenesis or cancer formation. I mean, if you have an 80 plus year old person who is ill and you don't have much in your armamentarium, you're not really sure whether an 80-year-old person has mounted an adequate immune response to vaccination. I think it's fair to use the drug. I think it's one of the drugs that we have which can be administered at home for what it's worth. So I would use it in a high risk individual. But I think the indiscriminate use is what we really need to curtail. Unfortunately, I've prescribed it to a couple of 82, 83-year-old people, and the next day I get frantic messages saying we've stopped giving it to our grandparents because, look at what the ICMR is saying. So I think the nuance gets lost sometimes, and we need to find that right balance where we use drugs, but we use it sensibly and rationally.
Well, the South Africans, the doctors I was interviewing, they have mostly, because muscular pain has been a key feature of Omicron as distinct from plummeting oxygen levels. And they have in SOS cases been using anti-inflammatory drugs like Brufen. That's the feedback, at least one has got from the South African doctors. One more question for you, Dr. Pinto, is that the Mumbai Civic Commissioner said that people were getting admitted to hospital for a single day, getting monoclonal antibodies and then being discharged. It's almost like some self-prescriptive paths that we're down again. Does this concern you?
No, it is concerning. I mean, a lot of arguments around COVID are made with what's the harm? All we have to lose is money, so why not take it? So the problem with the current antibody cocktail, which is available in India, or the two which are approved. So one is the Lilly antibody cocktail and the other is the Roche antibody cocktail. Both of them do not work for the Omicron variant, and which is why most countries facing an Omicron surge have stopped using it. While we continue to use it indiscriminately without bothering about whether it may or may not cause any side effects, and that is problematic simply because you're bringing COVID positive patients to a hospital when they could have been isolating at home. So you're exposing a lot of people in transit while they come to the hospital. You're offering them a drug which is quite expensive, which is 60 to 70,000 rupees if you give half the vial, which is what is recommended, and you really don't know whether it's going to benefit them at all. So again, I mean, if you use it out of desperation in somebody who has multiple risk factors, who understands the fact that there is a very tiny probability, you have that conversation with the patient, and the patient says, okay, fine, I'm ready to take that chance. I mean, there's no way for me to know for certain if a particular person has Omicron. But to use it across the board in the blanket way that it is being used right now is clearly problematic.
Dr. Mahajan, you've made a case to continue to test and isolate. We've seen some changes in the protocols here. A 7-day isolation period compared to a 14-day isolation period that was suggested earlier. You're seeing Iqbal Chahal saying that you could possibly test negative now within a span of 3 to 5 days. That's a really quick turnaround compared to the 14 to 16 days that we saw with Delta. What worries me is what we're doing to our schools, to our children, to our economy. Isn't it better to vaccines don't stop transmissibility, but isn't it better to kind of insist on vaccine passports than this kind of testing approach to Omicron?
I think vaccination is what is really saving the day with Omicron. And, if you look at the data coming out of the US, then the hospitals are getting filled with the unvaccinated. Luckily for us, the large metros in our country are pretty well vaccinated. Mumbai is 100% for one dose and about 90% for two doses. Delhi is just a little behind with 100% of one dose and about maybe 75% two doses. But think of areas in the country where vaccination levels are not of this at this high level. That's where, I'm a little worried as to what's going to happen. Maybe in these select cities, the one thing is definite, that policies that were in place for the Delta variant have to be changed for the Omicron, because that was actually, it led to serious disease. It led to a lot of hospitalizations. We were not, vaccination was just beginning. And so we cannot follow the same mandate. And I'm glad that ICMR and the government have also shortened the isolation and the time for by which you have to be isolated. So we cannot follow the policies that were there earlier. They definitely need to change, but let's also not take this so lightly, because people will die from it. People will need hospitalization, maybe not so much for oxygen and not use so much of ventilator beds, but also remember the data that we have is from South Africa as yet. Our data is still to come. And there, the average age, the median age was 36 for Omicron and 59 for Delta. So what happens when, the whole demographics change and those at higher risk with comorbidities and the elderly start getting the disease? Hopefully, it will still remain mild. But in our own setting, we as yet don't know that. These are still the early days of Omicron.
Fair enough. And thankfully, the one thing that has happened is that the Niti Aayog, Dr. V.K. Paul today has conveyed to the Election Commission that mass rallies cannot go on. This is something that has been really bothering citizens as politicians campaign but impose weekend lockdowns for citizens. And you're seeing some of those images there. The Delhi Chief Minister among those who after campaigning tested positive. So those are the kind of things that I think now people will not accept. There's a psychological threshold that has been crossed, I think, for the citizenry of this country. Dr. Lahariya, what's the one policy change you'd like to see compared from Delta to Omicron?
What is the one policy change which I would like to see? I would say that the science communication need to be increased between the way government communicate to the people about the risk of the COVID-19. More importantly, it is very important that what we know that, and this is through the modeling-based projection also, that Omicron wave would not be there across the country in one go. It will be in a phased manner. Initially might be the major city, then medium town, and then a smaller city. So we cannot expect a rural countryside right now to follow COVID appropriate behavior as diligently as someone living in Delhi or Mumbai should follow. So government need to say that the graded manner, the communication, that if there is a rise in the COVID-19 cases in your locality, adopt those COVID appropriate behavior. That's one thing which government should definitely do, and do it really well. And second part is, I would say that there is a lot of emphasis on hospital beds and hospitalization, ICU. It is not going to serve the purpose. What should we now know from Delhi and Mumbai that majority of cases are mild or people require consultation or testing. So attention has to be on strengthening primary healthcare facility, the smaller facility which can provide consultation to the people. So that is the area where attention should be. And third, we have already discussed that we should be focusing upon that the parameter of dashboard indicator need to change.
Okay, Dr. Pinto, a couple of things here. I was interviewing a lady who came in from France to meet her mother. She's a French citizen, but her mother is Indian. And she was institutionally taken to hospital against her will, to a private hospital with her 11-year-old son. She was entirely asymptomatic. So this business of institutional quarantining, institutional hospitalization, that's the first thing I think needs to go. That's, that's my belief. I don't know what you think. Secondly, we need a little more information on whether the hospitalizations that we are seeing are actually people being hospitalized for COVID, or are they being tested for COVID and being hospitalized for something else? Because that's actually what we saw happen in the United Kingdom. So
no, absolutely.
What is your, yeah. Go ahead.
I think these are two extremely important points, and I think institutional quarantine of international travelers or domestic travelers needs to absolutely be stopped. I think it makes some sense maybe when community transmission has not happened. This is a new variant. I think it's something that one needs to do, although we've never really succeeded at halting the spread of a variant which is spread through the world. But still, maybe it has some role in the initial phases. But once there's community transmission, I think it's a waste of resources. It's a waste of hospital beds. Most people who travel internationally have the wherewithal to isolate at home and do so very comfortably. So I think we shouldn't lose precious hospital beds for that. So I think that's an absolute no. To answer your second question, I think there are a couple of caveats. Everybody keeps asking me this question: Are they mild? Are they mild? That's the question that I get asked when it comes to hospitalizations. I think number one, it's early days. Most people with COVID tend to deteriorate towards the second week, and we're still in the first week of the surge. So the actual patients with hypoxemia, with drop in oxygen levels, we will anticipate somewhere in the next week. Right now, a lot of what we are seeing in the hospital are individuals who come in with heart attacks, individuals who come in with strokes, individuals who come in for surgery, and they are incidentally detected positive. And because they're in a hospital for a reason, you can't send them back home just because they're asymptomatic from the COVID point of view. So you put them, hospital beds start filling up with people who are in the hospital for other reasons. Now, unfortunately, when this happens, even though these individuals may not use much oxygen, these individuals may be mild, when the actual hypoxemic patients come in next week, let's hope that our beds are not in a status that we are not able to provide it to them. So I think that's a real fear that we currently have, coupled with the fact that healthcare workers will fall sick. We know healthcare workers have started falling sick across the city. So a lack of manpower plus a surplus in admissions for whatever reason, I think is something that's a real concern and we need to be concerned about.
So let me ask the controversial question: if healthcare workers are asymptomatic, and this is being discussed in the United States of America, where the CDC has reduced Lancelot the isolation required to 5 days, and people can release without a test, without a negative test. I think one of the reasons they've probably done it is for the sheer practical need to have more people at the front lines, right? Because if everybody is going to isolate for longer than 5 days, with this volume of cases, you will soon not have essential services. So, what should happen if healthcare workers are asymptomatic? Should they still be testing every day and isolating mandatorily?
No, I agree with the mandate. An added layer of protection would be a rapid antigen test. There is some suggestion that a rapid antigen test correlates reasonably well with transmissibility. So 5 days of no symptoms and a rapid antigen test coming negative would make it very unlikely that the person would transmit. Also, healthcare workers as a group tend to be very, very careful when it comes to masking. Most of us are in our N95s whenever we are in clinical areas. So the probability of them transmitting it, number one, if you're asymptomatic, you're likely to have a low viral load on day 5. The probability of you transmitting it is already low. Add to that the fact that you are more likely to be very careful when it comes to masking. I think it's fair to let healthcare workers come back sooner if they're asymptomatic. We are going to face a struggle otherwise. If we have longer periods of isolation and have a significant proportion of healthcare workers fall ill at the same time, we're looking at a lot of trouble ahead.
And that's what I want to take to you, Professor Bhramar Mukherjee, and then I'll give Harsh the last word. There is a practical dimension. There is a dimension of the economy. There is a dimension of essential services. There is a dimension of schools. In India, we just refuse to open schools. They're the first thing that are closed. And we've gone hoarse trying to urge governments to open schools. But even when schools open, a lot of parents just refuse to send their children to school. Now, when you have caseloads of a few lakhs a day, a million, the United States has hit a million a day, and we don't change the messaging around Omicron, I just fear you're going to lose another school year.
So I completely agree with you that this has been sort of like two kinds of messaging, that Omicron is nothing versus it's cataclysmic, right? So there is no middle road. I can tell you that at University of Michigan, we decided to go for an in-person semester again in the face of 1 million cases because we have a vaccine mandate. We are requesting a booster mandate from February onwards, and we have a mask mandate in buildings. And the evidence for classroom teaching-based transmission is very limited. So we have to really chart a middle course here that really distinguish between transmission and disease and use all the tools that we have really developed and worked very hard to develop, put them to use, and keep the society open in a safe way. There is less emphasis on that. There's a lot of hysteria. There is a lot of denial. There is no pragmatic way to make society run after 2 years of the pandemic. And we really need to emphasize that in terms of messaging. If one thing I'd wish for is that clear communication.
I think that's such an important point, and I'm so happy to hear about the in-person semester with these practical guidelines. Mask up, get your vaccine, get your booster shot. Harsh, is that sooner or later, and sooner, I hope, going to have to be the way ahead for us? And that very important distinction being drawn between disease and transmission, because one is not equal to the other.
That's very right. I think it should and probably will happen sooner rather than later, because we are seeing that the government appears to be more nimble-footed this time round and have taken quick decisions in the last 1 week. And so, and also for schools, actually, there's such a scare that's somehow got created. And children, we know, even with the Delta variant, when they got the disease, it was mild. And so we hope it'll be even milder with the Omicron, if we believe that Omicron is a milder disease. And we don't close schools when the common cold is on, which also is pretty transmissible. And this is what, at least in children, we hope it will be. And also you see huge enthusiasm in the 15 to 18-year-old for the vaccination, which started, and already millions of them have been vaccinated in the last 4 days. So I hope that we look at this third wave, which is Omicron mediated, differently. We approach it differently, both from the treatment, testing, as well as societal point of view, and not again go into our shell the way we did during the first and the second waves.
Absolutely, and I wish the government would spend some resources on setting up helplines that would help people to call in somewhere and say, okay, I've tested positive, what should I do next? You need simple SOPs, and you need the government to urge people to not go to hospital in panic. Please do remember that there are other diseases like tuberculosis, cancer, and kidney disease that are fatal, especially for India's poorest patients. And when we go and occupy a hospital bed using our relative privilege, we are taking away that bed from someone who needs it more. So that is also something to underline at this point. Thank you. This has been an extremely enlightening conversation. Lancelot, Harsh, Chandrakant, and Bhramar. Pleasure to our panel. Thank you to our panel of experts. Pleasure learning from all of you. And yes, the numbers are going to spike up. We need to be mentally prepared, but understand the distinction, I think, as one of our guests said today, between transmission and disease. And hopefully our vaccines will continue to protect us against disease and death. And that's where the vaccines are working, and don't let anyone tell you otherwise. Thank you for watching. Goodbye. It's great to see you here. Thank you for watching our work. If you haven't subscribed yet, don't forget to click the bell icon and subscribe to Mojo Story and support independent, robust journalists.